Welcome to Talking Type 1 Diabetes, a podcast series for healthcare providers who manage or treat type 1 diabetes, or those who just want to learn more about this life-changing progressive disease. Each episode features conversations between leading experts in the fields of endocrinology, primary care, and diabetes care. This episode explores the efficacy and safety of TZIELD, as well as evidence from clinical trials demonstrating how treatment with TZIELD can delay the progression of stage 2 to stage 3 type 1 diabetes. You will hear from Dr. Bryce Nelson, the Chief of the Division of Pediatric Endocrinology in the Department of Pediatrics at VCU School of Medicine and Children's Hospital of Richmond in Richmond, Virginia, and a Professor of Pediatrics and Medical Director of the Pediatric Diabetes Program at VCU School of Medicine. You will also hear from Dr. David Robertson, an endocrinologist at Atlanta Diabetes Associates and the Piedmont Hospital Atlanta, both located in Atlanta, Georgia, and an adjunct clinical faculty member in the Division of Endocrinology and Metabolism at Emory University Scholarship in Atlanta. Dr. Nelson and Dr. Robertson are being compensated by Sanofi for this podcast episode. TZIELD is a CD3-directed antibody indicated to delay the onset of stage 3 type 1 diabetes, T1D, in adults and pediatric patients aged 8 years and older with stage 2 T1D. Please see important safety information on screen and additional important safety information and full prescribing information provided at the end of this episode. To kick things off, let's take a look at the clinical application of TZIELD and who qualifies for TZIELD treatment.
So, Dr. Robertson, it's been an exciting couple of years. I know that I've been pretty excited that we've been able to use that here in my local community, but when you're talking to your patients who may qualify for this, how do you kind of discuss TZIELD and who qualifies for it and who is it appropriate for?
Well, I explained to them that we're focusing on patients with what we call early type 1 diabetes. What does early type 1 diabetes mean? That means that the blood sugars have not yet reached type 1 diabetes stage 3. Type 1 diabetes stage 3 is where we initiate insulin therapy and manage with insulin for the rest of their life. In early type 1 diabetes, what we call stage 2 diabetes, patients have begun to have abnormal blood sugars. Every time they ingest calories, every time they have a meal, their blood sugars become more elevated than they should, and they stay elevated longer than they should. We can see those elevations in two different ways. One way is simply to wear a continuous glucose monitor and look at the patterns that different meals induce and see that the majority of meals do have this exaggerated and prolonged period of hyperglycemia, but that they eventually turn back to relatively normal blood sugars. If you were to check an A1C, it would still be in the 5.6 to about 6 range. The alternative way to check this, the more formal way to assess for early type 1 diabetes, what we call stage 2, is to do a 2-hour oral glucose tolerance test. In this case, we expect that 1 hour after challenge blood sugar to be above 200, to be clearly abnormal, but the 2-hour to be below 200 but not yet back to 140, which would be a normal 2-hour. So either by wearing sensors or by doing glucose tolerance tests, we check those patients that we know are at risk for stage 3 to see have they transitioned from normal blood sugars to abnormal blood sugars, and if they're in that transition phase, they're eligible for treatment to delay the onset of stage 3.
Yeah, I agree. And one of the ways that I kind of approach it too is really trying to explain what it means by early type 1 diabetes. And I usually do two things with that, and that is, one, I make sure that people understand that the diagnosis of type 1 diabetes is based on the presence of two or more antibodies. which is a little bit different than what people are used to. I'm not sure about how you were taught in medical school, but I know for me, we follow the ADA criteria, looking at blood sugars, and so for me, I've really focused on making that distinction, and that early type 1 that the diagnosis of type 1 diabetes is made by the presence of 2 or more diabetes-related antibodies, but that hyperglycemia, elevations in blood sugar, help us define the progression through the stages. So these early stages of type 1, like stage 1 where we have antibodies but we have normal blood sugars, or stage 2 where we have antibodies but we're starting to see abnormal blood sugars but not quite in diabetes range yet, and then stage 3, which is what we all recognize as diabetes, where we have, it's just type 1 diabetes, where we have sustained elevations of blood sugar that require insulin treatment. So that's how I really try to set the stage with what those stages mean, and so people understand what we mean by early type 1 diabetes, and that we now have a medication like TZIELD that has been shown to delay that progression from stage 2, where people have abnormal blood sugars, to stage 3, to where they have sustained hyperglycemia that requires insulin treatment, so that it's prolonged that timeline along the degradation of the blood sugar response.
Thank you to Dr. Nelson and Dr. Robertson for sharing their valuable insights on identifying appropriate patients for TZIELD. Please note that early T1D includes both stage 1 and stage 2 T1D. However, TZIELD is only approved for use in patients age 8 years and older with stage 2 T1D.
So, Dr. Robertson, I'm curious how you explain it to your patients who potentially could benefit or would be eligible for TZIELD. I know that the families that I work with as a pediatric endocrinologist, I'm certainly focused on making sure they understand, one, that type 1 diabetes is an autoimmune condition, and what that means. So that way then I have the background for how I can explain how this works. And so just as we know that this medication in those with stage 2, it actually is something that is able to target the specific cells that may be attacking, so that we can prolong their time in that stage 2. How do you kind of address that with your patients?
So I think it's a little bit complicated for the patients to understand sometimes that antibodies are causing the disease and we're giving them an antibody to treat the cause of the disease. So I want to help them understand very clearly that stage 2 early type 1 diabetes is a situation where there's an ongoing production of autoantibodies, antibodies directed against their beta cells, their cells that produce insulin, and a certain group of T lymphocytes are making those antibodies. What we're giving them is a protein, which is also an antibody, but it's an antibody that attaches to a protein on those lymphocytes. And by attaching to that protein on the lymphocytes, it activates and then basically burns out or reduces so significantly the number of those lymphocytes that the injury to the beta cells is interrupted. And that's our goal, interrupt that injury. And the way we interrupt it is to target the cells that are causing the injury, that are producing the proteins, the antibodies directed against the beta cell. So yes, we're giving them an antibody, but that antibody is not directed at anything in the pancreas. It's directed at an immune cell that is producing the proteins that are injuring the pancreas. And there's many different proteins that could be involved, but they all come from the same type of cell. And fortunately, one antibody against one protein on those types of cells allows us to regulate that immune response.
Yeah, one of the challenges I've really had over the last 2 years in introducing this, it's been a wonderful time, but still have the challenge of this is something new. How well is what is really known about this? How did this get approved, and how do we know that this is going to be something safe that either I can take or my child can take? So I'm curious about your approach, how you talk to people about both, when you're trying to talk to potential referring physicians, or some of your patients. And one of the, when we're talking about trying to be able to use or have people consider using TZIELD. So, I think it can be kind of a challenge. I wonder how you kind of approach that. Be curious.
Well, I do have a bit of a personal advantage in the sense that our center has been involved in teplizumab since the very beginning. So I literally have patients who received the medication over 15 years ago. And so it is something, so when I talk to a patient, I say that over the last 25 to 30 years, many different treatments to delay or reverse early type 1 diabetes have been trialed, and unfortunately we have seen many disappointments. But of all of those drugs that we tested over the last 2 decades, this single drug emerged as the most promising. And this single drug has been tested in numerous different ways in numerous different studies before the final study that was used to bring it to market. And that final study was based on all of the information we learned from patients who had been given this drug under different early type 1 diabetes circumstances. So what we now have is a body of knowledge based on many pre-existing studies focused on one definitive study. And that definitive study looked at children over 8 and adults who were in that pre-diabetes stage. They came from families where there was a history of type 1 diabetes and an understanding of what life with type 1 diabetes meant, and the families were open to the possibility of exploring a treatment. And so we looked at eligible individuals, we screened eligible individuals, and for those in whom there was no safety barrier to receiving therapy, initiated therapy, treated them over 2 weeks, and then followed them for 4 to 5 years, and gained a lot of insight about whether treatment produced any lingering benefits or any long-term harm. And we focused really on safety throughout those years of follow-up. And we do know that there are some important safety factors to monitor during the first few weeks, including the 2 weeks of therapy and the first several weeks after therapy. But fortunately, we haven't seen any downstream effects that suggest there's a long-term adverse outcome associated with that 2 weeks of therapy. And so I try and emphasize to patients that although this is a relatively new to market drug, this is anything but a fresh out of the box approach that we're hoping to learn more about.
Well, and I do something very similar, and I take advantage of some of my experience on the research side, because I was involved in that trial and I had experience with this medication on the research side, and following patients and had recruited several patients into that study, and so I certainly felt like it gave me some sense of comfort and experience that I could bring to us getting this started at my institution, so that we can try to make this available for folks. And as I think that we may agree, I mean, it was a well put together study. It was a randomized, double-blinded, placebo-controlled trial. And I think one of the strengths of it, from my bias as a pediatrician, is that so many children were enrolled in that study, and I think that really helped us get the FDA indication, and because it provided some pretty clear evidence in that population of the benefit. So I think that when we look at that and look at some of the outcomes we saw with that, with the pretty significant delay in the progression from stage 2 type 1 diabetes to stage 3, where there was a median slowdown of about 2 years. So that was something that was significant. And so moving past the statistical significance, when I talk to families who, and this is often in families who have children with type 1 diabetes already, and so we're now screening or treating their siblings who may be in stage 2 type 1 diabetes, that 2 years is worth any amount of price. So 2 years could potentially give families will say 2 years will give me more time during puberty. 2 years will help me, potentially, bridge that time where I'm trying to get them through high school into college. I mean, it's a varied response, but in general, I've heard from a lot of families that that amount of time potentially, and not everybody is 2 years, as that just happens to be the median time, but any degree of slowdown in that progression has extremely high value to families and patients, I think.
Thank you to Dr. Nelson and Dr. Robertson for your practical insights. Your discussion on TZIELD's patient eligibility and its demonstrated efficacy in delaying the onset of stage 3 type 1 diabetes in patients 8 years and older with stage 2 T1D will undoubtedly help our listeners in their clinical practice. Our next topic is the safety profile of TZIELD. We'll cover key safety information that both patients and healthcare professionals should be aware of.
So we explain to them, you need to be healthy going into the infusion. We need to make sure your blood counts are good, that your immune system and your bone marrow are generally functioning well. We need to make sure you're not sick currently and that there's been no recent viral infections. It may affect your ability to benefit from a immunization. So if you've had a recent immunization or need one urgently, that could affect the timing for this therapy. And we need to make sure the liver tests are good. And the dosing of TZIELD is ramped up gradually over 5 days. So if those tests are good before we start, we want to check and make sure there's no change in the white blood cell count, or particularly the lymphocyte count. The lymphocytes are the cells that we're targeting. During those first 5 days, we want to check labs a couple of times. If they've stayed in a safe range, we can continue the infusions and monitor those labs a couple of more times. Likewise, we monitor the liver tests. Typically, patients do see a drop in their lymphocyte count. We do know that that's how the drug works, but as long as it doesn't drop too severely and that the white blood cell count overall remains reasonable and the liver tests become only minimally or not at all elevated, we can proceed with the infusions. That it's important to let the families know that there's a clear scheme for monitoring treatment, that they will be getting a daily infusion. It will be ramped up gradually. And then I'm sure as you've experienced with your patients, everybody has a few side effects. It's not something that you just, I'm not sure if I got it or not, which kind of made it hard in the blinded studies to truly stay blinded, because when people sailed through, we tended to kind of assume that they weren't getting anything other than salt water. But in the real world, everyone has some effects. What kind of side effects do your patients experience with their daily infusions?
Yeah, so I've certainly seen the most common side effects that we all know about. So the three most common, as you mentioned, one of them was the decrease in the lymphocyte counts and the leukocytes, headache and rash. Those big three are certainly something you see. And one thing I think is important is, just like you mentioned, is educating the patient, making sure that they are aware of what the side effects they are so that they know to be anticipating them. And then also ways that we, try to help prevent the side effects. And what do we do if you do experience the side effects? And so while most of these side effects are relatively mild and can be treated and pre-treated, so I know you likely do this before we start the infusions for individuals each time, we usually pre-treat them with Tylenol or acetaminophen, often also with Zofran and anti-nausea medication. And then Benadryl or Claritin or Zyrtec and antihistamine, that we can try to help prevent some of the acute infusion reactions, help try to prevent rash, help try to prevent headache. But if they do experience headache, we can easily treat that usually with acetaminophen. And rash can also be treated with antihistamines, and those tend to go away. I always make sure that they understand about the drop in the lymphocyte counts, because we're watching those. And certainly, like you, I watch to see where does it go down and are we starting to return? Because up to 80% of patients in the landmark trial had drops in their lymphocyte count. But we also know that those lymphocyte counts really return mostly back to normal within 14 days, but most in the study were back to normal within 21 days. So then that when we, and I also make sure people understand some of these effects, because when they go home, they could potentially have rash at home, or they can have headache at home, so that we can try to get them treated while they're at home, and they're still going through some of the infusions. And then just to make sure that they have follow-up, like you said, because some of the effects can linger for even up to a week or so after the infusions. I've had some patients have some things, that some of these more common side effects. Now, some of the more serious side effects you were kind of alluding to is, we want to make sure that patients and providers are aware of cytokine releasing syndrome, which is a very serious side effect of this, where they can have kind of an overproduction or over an exaggerated response from the immune system that can cause lots of problems and lots of side effects, and can affect their liver. So we monitor their liver function, just like you were saying. And that, while it is a very serious side effect, it was a relatively rare side effect in that study. Then monitoring people over time. I think that we're still in the infancy of what exactly is the standard protocol for how we follow these individuals over time. But certainly making sure we keep an eye on their blood count, their liver function tests, keeping an eye on what their blood sugars are doing, how those may be changing or not changing over time as we're seeing these patients back.
Yes, so we can set realistic expectations. We can know that there'll be careful, close monitoring of their situation during the infusions, after the infusions, and that long term, we're going to continue to watch for any change in their blood sugars that might indicate a need for treatment. Every patient's a little bit different. No treatment is 100% successful, and any patient at any day could develop stage 3, but everyone's different. So we're going to be part of the team, and they're going to meet with us, and we're going to meet with them on a regular basis during and after the infusions. And I reassure them, especially if they're doing home infusions, that the infusion nurse and I are talking on a regular basis. The infusion nurse has 24/7 access to me, and they have 24/7 access through my answering service to me, that they're never out there on their own. And the infusion nurses that I've worked with have been really good at, one, keeping me informed, and two, making the family aware that communication's occurring, and that they'll share any information that should be shared immediately.
Yeah, and that was and actually a pretty important thing when I first got our program started here. Is really engaging our pediatric infusion center and infusion nurses, because while they didn't have any experience with TZIELD, they certainly had experience giving other medications that are immunologic or monoclonal antibodies. So they were, when we reviewed some of the side effect profiles, they were side effect profiles that they were used to helping the practitioners and the providers monitor for. So that, I think that really helped us here where I'm at to really help get our program kind of off the ground, is having the infusion, and certainly working with the home infusion nurses that I've worked with. They always get great training before we do the infusion, so that they're up to speed on what it is and what to help monitor for. And then, like you said, the access to us so that we can help them troubleshoot any issues that they're having.
Thank you to Dr. Nelson and Dr. Robertson for reviewing the TZIELD clinical data, efficacy, and safety information, and highlighting how we have the potential to delay the progression of stage 2 to stage 3 T1D. The TN10 trial was a phase 2, randomized, double-blind, event-driven, placebo-controlled study in 76 patients, 8 to 49 years of age, with stage 2 T1D. In the TN10 trial, patients treated with TZIELD spent twice as much time in stage 2 compared to the placebo group. The median time to stage 3 onset was 50 months for TZIELD-treated patients versus 25 months for those on placebo. This represents a hazard ratio of 0.41, with a 95% confidence interval of 0.22 to 0.78 and a p-value of 0.0066, all determined by an adjusted Cox proportional hazards model. For patients already in stage 2 T1D, the median follow-up time in this trial was 51 months. Please remember, individual patient results may vary. Please refer to the full prescribing information for additional details on the clinical trial results. Thank you for listening to Talking Type 1 Diabetes, a podcast series for healthcare providers who manage or treat type 1 diabetes. Be on the lookout for other episodes of the Talking T1D podcast, available on TZIELD-HCP.com and YouTube. For more information regarding TZIELD, visit our website at TZIELD-HCP.com. Please be aware of the TZIELD indication and important safety information, indication and usage. TZIELD is a CD3-directed antibody indicated to delay the onset of stage 3 type 1 diabetes in adults and pediatric patients aged 8 years and older with stage 2 type 1 diabetes. Warnings and precautions. Cytokine Release Syndrome, or CRS. CRS occurred in TZIELD-treated patients during the treatment period and through 28 days after the last drug administration. Prior to TZIELD treatment, premedicate with antipyretics, antihistamines, and/or antiemetics, and treat similarly if symptoms occur during treatment. If severe CRS develops, consider pausing dosing for 1 to 2 days and administering the remaining doses to complete the full 14-day course on consecutive days. Or discontinue treatment. Monitor liver enzymes during treatment. Discontinue TZIELD treatment in patients who develop elevated alanine aminotransferase or aspartate aminotransferase more than 5 times the upper limit of normal, or ULN, or bilirubin more than 3 times ULN. Serious infections. Use of TZIELD is not recommended in patients with active serious infection or chronic infection other than localized skin infections. Monitor patients for signs and symptoms of infection during and after TZIELD administration. If serious infection develops, treat appropriately and discontinue TZIELD. Lymphopenia. Lymphopenia occurred in most TZIELD-treated patients. For most patients, lymphocyte levels began to recover after the 5th day of treatment and returned to pre-treatment values within 2 weeks after treatment completion and without dose interruption. Monitor white blood cell counts during the treatment period. If prolonged severe lymphopenia develops, less than 500 cells per microliter lasting 1 week or longer, discontinue TZIELD. Hypersensitivity reactions. Acute hypersensitivity reactions including serum sickness, angioedema, urticaria, rash, vomiting, and bronchospasm occurred in TZIELD-treated patients. If severe hypersensitivity reactions occur, discontinue TZIELD and treat promptly. Vaccinations. The safety of immunization with live attenuated live vaccines with TZIELD-treated patients has not been studied. TZIELD may interfere with immune response to vaccination and decrease vaccine efficacy. Administer all age-appropriate vaccinations prior to starting TZIELD. Administer live vaccines at least 8 weeks prior to treatment. Live vaccines are not recommended during treatment or up to 52 weeks after treatment. Administer inactivated, killed vaccines or mRNA vaccines at least 2 weeks prior to treatment. Inactivated vaccines are not recommended during treatment or 6 weeks after completion of treatment. Adverse reactions. Most common adverse reactions, more than 10%, were lymphopenia, rash, leukopenia, and headache. Use in specific populations. Pregnancy may cause fetal harm. Lactation. A lactating woman may consider pumping and discarding breast milk during and for 20 days after TZIELD administration.